So I was asked to give a talk on understanding responses to cancer therapy, lessons learned from melanoma. And so we've made tremendous advances in cancer therapy through the use of molecularly targeted therapy, also immunotherapy, and melanoma is really a prime example. In the case of metastatic melanoma, we now have over 10 new regimens approved within the past 5 or 6 years for the treatment of patients with advanced disease. And we certainly as a group have focused on better understanding which patients are going to respond to therapy, which patients won't respond to therapy, and why, and then strategies that we can actually use to make patients respond better. And so my laboratory has focused on understanding therapeutic responses, and what we're starting to learn is that it's not only the tumor itself but also the tumor microenvironment, and then we have a greater appreciation of the role of the immune system and also, interestingly, the environment and how the environment can actually influence cancer development and also how a cancer responds to therapy. And one of the key features of that is actually the microbiome. And so yesterday I offered some insights into how the tumor genome and epigenome can actually influence therapeutic responses, how the tumor microenvironment can shape how a cancer develops and how it responds to therapy. Also how the immune system can mold cancer responses. And then finally really touched upon how the bacteria within our bodies can actually influence how patients respond to cancer therapy. And it's quite profound. And so what we found, so certainly other investigators have laid the foundation for this, including Tom Gajewski from the University of Chicago and Laurent Zitvogel, from Gustave Roussy, have really, in preclinical models, really laid the groundwork that bacteria within the intestines of mice can actually modulate how cancers develop and how they respond to different forms of treatment, like immune checkpoint blockade. So we wanted to understand if that was happening in patients, and so we enrolled a large number of patients, over 300 patients with metastatic cancer, in this case melanoma, who were undergoing treatment with systemic therapy, and looked at the role of the microbiome and how they were responding to that cancer therapy. And interestingly found really night and day differences between responders and non-responders with regard to both the diversity and the composition of the gut microbiome or bacteria that are actually sitting there in the intestine. Not far off, and so certainly people are using fecal transplants, to treat other diseases, including, Clostridium difficile. When patients get C. diff and they get super infection, you can actually give them back a normal microbiome and really, cure them of their C. diff. The fecal transplants also being used in the context of inflammatory bowel disease and other diseases. The question is, can we use it in the treatment of cancer? And I think it's a resounding yes. So we're planning clinical trials where we actually use fecal transplant in conjunction with treatment with checkpoint blockade to see, if we can actually enhance responses to checkpoint blockade. And so that's one form of, how you can actually change the microbiome. There are also, can we create customized, pills, that contain components of the microbiome, both prebiotics and probiotics, to actually enhance cancer treatment. And I think, again, I think the answer will be yes. There are complexities that exist with that kind of a therapy, and we're certainly working on that with a number of other investigators worldwide. We're also working with the Parker Institute for Cancer Immunotherapy on, partnering up, and really trying to find the best way to do this. First, I think we've made huge advances, and I think we need to reflect on that and say, okay, we've come a long way, but we still have a lot to learn. We have not cured cancer yet, but we've made significant inroads. So I think, what are the take-home messages beyond that? I think, we have to take on a more holistic approach to cancer therapy, where we consider not only, the tumor genome, epigenome, microenvironment. We also have to critically consider the role of the immune system, in fighting cancer, and then also the role of the environment, not only the microbiome, but other environmental influences, diet, stress, things like that can actually influence how cancers develop and how they respond to different treatments. But I think a major a major component is that we really need to work together as a team globally, to really make the biggest advances in cancer therapy. We had another talk yesterday where a graduate student in my laboratory, Vanchaswaran Gopalakrishnan, presented some of our data that had been previously presented at ASCO SITC, where he basically went over the results of our studies looking at patients who were with metastatic melanoma who were going on to treatment with immune checkpoint blockade, and how we profiled both the oral and gut microbiomes. And so he presented that data yesterday, again kind of highlighting that that there were no clear differences in the oral microbiome between responders and non-responders to therapy, but there were very significant differences in the diversity and the composition of the gut microbiome in patients going on to PD-1 based therapy. We also have another abstract that's being presented by Dr. Scott Woodman, and that's being presented on Tuesday, where we have certainly, because we've made all these advances in patients with melanoma with late stage disease, can we bring these advances to patients with earlier stage disease? And so we know that over half of patients with melanoma have a mutation in a gene called BRAF, and that you can actually target that mutation therapeutically by using BRAF and MEK inhibitors. Now that's been pretty successful in the treatment of stage 4 disease, and so we asked the question, can we bring that to patients with earlier stage disease? And so we studied a cohort of patients with bulky stage 3 melanoma, where they have melanoma that's spread to the lymph nodes. And we basically, if they had a BRAF mutation, we did a study where they were either treated with conventional upfront surgery, which is the standard of care, versus treated with BRAF inhibitors before they were taken to surgery, and then they got BRAF and MEK inhibitors after. And Scott, Dr. Woodman will be presenting those results tomorrow, but it basically showed that, for patients with metastatic melanoma that's localized to the lymph nodes, if they have a BRAF mutation and you treat them with a BRAF inhibitor before taking them to surgery, first, their risk of the disease coming back is significantly lower than if you had taken them straight on to surgery. Secondly, that the treatment is associated with about a 58% of patients you don't actually find any viable tumor at the time of surgery, meaning it's highly effective, when you treat them before surgery. And then we found, in the patients whose tumor didn't completely go away, we found mechanisms of resistance that could actually be targeted. So could you actually give someone additional medicine on top of the BRAF and MEK inhibitors to make the therapy more effective, either something like an ERK inhibitor or something like checkpoint blockade, and make this form of therapy much more effective.